So my name's Amelia. I'm a Gumbenga woman from Coffs Harbour, so Sawtell area, a little bit south of Coffs Harbour. I'm a clinical nurse specialist in oncology, and sorry, I'm just a little, the slide won't go up. That's not fair, is it? No, thank you. So basically, I've been part of running a 12-month project and playing part of Aboriginal Liaison nurse in our oncology setting. The role come about because unfortunately we were noticing some of our patients weren't having the best cancer care journeys, and we thought there were just a lot of gaps in their care. During my postgrad certificate, a lot of literature reviews, there's a lack of a lot of evidence out there, but a lot of research indicates that support people in these settings, such as liaison nurses, really help in closing the gap for these patients. So just a little bit of the facts and the background behind the project. So in recent years, cancer mortality for Indigenous people has increased by 16% compared to non-Indigenous people, when it's dropped by 10%. Indigenous Australians are less likely to have screening tests for cancer, high levels of comorbidities and poor access to treatment, and they complete less treatment, so that comes back to compliance as well. The average life expectancy of Aboriginal and Torres Strait people remains an average of 10 years lower than non-Indigenous people, and smoking within the Indigenous communities is higher than the rest of the population, and that may contribute to the fact that Indigenous Australians are 1.9 times more likely to get lung cancer and other cancers as well. So some of the barriers that we identified in the healthcare is Indigenous Australians, they have a collective experience of racism and marginalism, and that can often result in the issues that what we perceive to be issues in treating them. Patients can often say they understand when they don't, and remain silent if they don't want to communicate, and this can often be misconstrued. There's a limited understanding of how the healthcare system works, so they can find it difficult to navigate through the system and appointments and treatment and so forth. They often have poorer housing and overcrowding in the housing that they do have. The people living in rural and remote areas obviously face financial burden to get to the treatment centres, and research suggests that the further a person lives away from treatment centre, the poorer the cancer outcomes as well. So the concept of time with Indigenous Australians can affect cancer outcomes. So as previous presenters have mentioned, family is of priority, and so they may miss appointments because something more important comes up, and that can create issues with their treatment and so forth. So there's a limited understanding of what cancer is, or fear of attending clinics because of the negative experiences they've had in the past. Traditionally, cancer's been seen as can be seen as a payback or a curse as well, as someone said, two next door, a white man's disease. It can be seen as incurable, and the treatment's often excessively toxic. There's actually no word in Aboriginal languages for cancer, so there's over 200 different Aboriginal lingos. Not one of them has a word for cancer. Can be seen as contagious disease that needs to be avoided, and people can feel shameful, which leads them to be reluctant to talk about their experiences within the community and family, and not present for screening and treatment. They often lack knowledge on the type of symptoms of cancer and the treatment options available. So in the literature review that I did, there are a lot of patient reflections about why these kind of roles were necessary, but the one we used in the brief to have the position approved was this one by Loretta, and she said she thinks there needs to be a person, not necessarily a caseworker, but a support worker, ideally an Aboriginal person who has some awareness about cancer, has awareness about the referral pathways so that they can support the person. Someone who has empathy and understanding about Aboriginal people and their culture, so they can mentor you through the journey. Often it's a journey you travel once and you don't know where you're going. So part of the role has been providing education sessions for fellow colleagues of mine and other staff within the oncology setting that I work in. And a big issue was patients identifying and them not being referred on to the liaison position. So a lot of people make the assumption if, they don't look Aboriginal, they're not, and they weren't actually asking the questions. So providing education to our admin staff has increased the numbers being identified. And this slide just resonates about being Aboriginal has nothing to do with the colour of your skin or shape of your nose. It's a spiritual feeling, an identity you know in your heart. It's a unique feeling that may be difficult for non-Aboriginal people to fully understand. So the aim of the liaison nurse was in line with the Cancer Australia framework in closing the gap. So we aim to enhance the quality of the patient care and in turn increase screening, compliance and completion rates of chemo and radiotherapy. Makes it easier for the Aboriginal people to trust that the healthcare system is there to help them. So the moment that they identify someone there as a support person who's a nurse, has understanding about chemo and is Indigenous, they often feel at ease and more willing to listen to their options and comply with treatment regimes. It's a link between services, so I work closely with the primary healthcare networks and other allied health around our local health district. Allows effective engagement with communities and in turn should allow effective and sustainable solutions to be created. So part of creating the role, I liaised a lot with the Aboriginal medical services, met with the elders of the community and had their input on how the role might be effective. So patients that identify as Aboriginal or Torres Strait Islander are supported in a culturally appropriate manner through their cancer care journey. And part of that has been through the education that other nursing staff are able to provide equally culturally appropriate care. Patients have a better understanding and we have a better understanding of the needs of the circumstances of other health professionals through education to empower them to provide, like I said, culturally sensitive care. So the referral process, we receive referral from the GP for our medical oncologist or radiotherapist. The administration staff contact the patient and ideally ask the patient then if they identify or not. An electronic referral is then sent to the liaison nurse and then the liaison nurse contacts the patient often before they start treatment so they know that link's there and it's followed up with a face-to-face meeting. And they also have a lot of outside referrals from community health and primary health networks. So progress to date, so we've consulted with 37 patients, so number doesn't sound a lot, but in previous years only half that number, 11 to 15 patients were being identified in a 12-month period, so not sure if that's because patients feel more comfortable to identify if the word's getting out in the community or if it's a coincidence. So interactions have included a lot of phone support, face-to-face consultations. So in the phone support, just calling them, remind them of their appointments, seeing how they're feeling, can also check if they're taking their medication for their chemotherapy correctly, refer on if necessary, organising transport, home care, referrals to palliative care. I'll work closely with social work and allied healthcare members too to make this all happen. The nurse is able to assist in the coordination of care in a culturally sensitive manner and patients have complied more with treatment. We had a few patients have issues with transport, appointments, finances, and just having that link there helped the liaison do that work, took it off their plate and they were able to follow through and complete their chemotherapy when they otherwise wouldn't have. Patients have expressed increased satisfaction and comfort through their cancer care journey by having an identified and experienced nurse to help support them. And so I've worked closely with a nurse researcher from the university in Coffs, Southern Cross University, and my nurse unit manager, and part of the evaluation has been a patient survey, which was conducted by an Aboriginal health worker who identifies, and she spoke to the patients for us. So the role's been 12 months now, 1 day a week, and we wanted to submit a brief to potentially increase it to 0.5 so that we can further embed the role into the community. And just some of the feedback from the patients was that it's the best thing, that the liaison can go to their appointments and refer them on to palliative care and checks on them. They pick up things that they might have missed, help fill out forms, made them feel at ease. Yes, it's wonderful. They sit down and explain things to you. Doctors tell you things, but the liaison explains things to you so you can understand. So it's also made them feel safer culturally within their treatment. So just the presence helps by just being there. She has always acknowledged me when I was there, which helps. And she has been beside me when I'm at the unit. She sits with me and explains things. She's my rock. And just having her around makes me feel assured. We wanted to know if they've shared their experience with the community, because that was a big part. We want the community to be aware that this role is available, so if they're diagnosed with a cancer, that they will be more likely to come and have their treatment. One of our patients said, yes, everything's a Facebook post. One of them said they shared all the information they got, and they talked to all their family. It was pretty positive feedback. This one about follow-up during your cancer treatment. So through the liaison, I helped to reconnect with my sister. Before this, my family was all over the place. So that was just a bonus. And the patient that gave that feedback was actually the patient that inspired the role in the first place, who was wanting to relocate because she wasn't happy with her treatment. So just her feedback alone made the 12 months worthwhile. Always there for a yarn. She's put me in contact with palliative care and explained different things to me. And it was good to have her there to talk things through and give us another way to understand. Support for the family. So patients fed back mostly that they had a lot of information that they shared with their friends and their family. So the conclusion was information received back from the survey. So we've submitted the report on the program to increase the hours, as I mentioned. And we really hope that then enables the liaison nurse to get out into the community more and participate in screening prevention programs in conjunction with the Aboriginal Medical Services to build rapport better with the community and be a face for them to identify with. So with increased community awareness of the role and the cultural security it can provide to patients having oncology therapies, it's anticipated that the compliance and completion rates will continue to increase. Thank you.